Hi everyone, welcome back to another video. And last time we talked about the timeline of pregnancy, and we also talked about the misconceptions and differences in definition between abortion, delivery, and termination. And before we move any farther, I want to clarify that, in my opinion, it does not matter if you have a medical reason or not. You should have full autonomy and be able to decide for yourself if you want to carry a pregnancy to term or not. That is up to you. So I do not think it is okay to force anybody to be pregnant who does not want to be pregnant. Okay? So just going forward, I'm not saying that there should be a certain definition of when people should be allowed to get an abortion or termination or not. That is up to that person. But what I do want to do is I want to take this conversation out from being a black and white issue, because it is absolutely not a black and white issue. There's a lot of gray area here. So let's say we have somebody who is pregnant who does want to carry the fetus until term. That might not always be an option. There might be some medical contraindications to carrying the pregnancy longer. There's some instances where you have to gamble because either they both die or you deliver the baby and maybe the baby lives, maybe the baby dies. That is a real situation that we have to make these decisions about. So essentially, I'm trying to explain why we need some leeway in legislation with regard to termination, because if you have a medical emergency, we need to be able to act on it. We need to use our best judgment and take those gambles if we need to in order to save lives, because we can't always follow a textbook. And something that I've actually heard from people have said that there's no reason medically to kill the fetus in order to save the parent. And this is largely true, because we're not trying to kill the fetus. That's not part of this. Again, termination is with regard to a non-spontaneous ending of the pregnancy. We are ending the pregnancy. It has nothing to do with if the fetus lives or dies. There is no reason to kill the baby. However, there are medical reasons to end a pregnancy. We're going to talk about some of those today. Specifically, we're going to talk about hypertension in pregnancy, specifically about preeclampsia and eclampsia, because these are reasons why we might need to deliver before a baby is viable. And when I say viable, usually we're going to be in the preterm period, but as we will see with eclampsia, you might need to deliver in an earlier period, even before they're viable potentially. So what do we mean by hypertension in pregnancy? So there are a few different categories of hypertension in pregnancy. The first one we're not really going to touch on today, but I did want to mention it, is gestational hypertension. And this is kind of, if we thought of hypertension as a spectrum within pregnancy, gestational hypertension is going to be the most mild end. And this is just any high blood pressure after 20 weeks of gestation. And when we say high blood pressure, it's usually greater than 140 systolic over greater than or equal to 90 diastolic. So if you have that kind of range of blood pressure after 20 weeks of gestation, you have gestational hypertension. If you have high blood pressure before 20 weeks, it's considered chronic hypertension and not gestational. So gestational just refers to that at or after 20 weeks of gestation. But the difference between gestational hypertension, and we're not going to talk about this today, I said this before, we're not going to talk about this today because we're not going to change our treatment based on this. We're essentially going to try to monitor the blood pressure, keep it below the 140 over 90, but we're not going to deliver preterm based on a diagnosis of gestational hypertension. It has not been shown that this improves outcomes. Where we start getting into this is with preeclampsia. So there are two categories of preeclampsia. You can have preeclampsia with severe features and preeclampsia without severe features. And the delineation of these two categories has been changed in the recent years by ACOG, because it used to be very clear lines between severe features or without severe features for preeclampsia. It is no longer that clear of a definition. We'll talk about the differences, but there is a lot of gray area between what is defined as severe features or not severe features. But depending on how you label this type of preeclampsia determines how we treat it. It determines when we deliver the fetus. So that is important that we understand that there are two different categories, and you have to use your clinical judgment in order to take the appropriate risks and put a patient into one of these two categories for their risks with the pregnancy. And then, of course, we have eclampsia, and this can also be lumped in with HELLP syndrome, but we're not going to talk about HELLP syndrome today. We're going to talk about that in a different video along with acute fatty liver disease of pregnancy. But we're not going to talk about that today. That's a whole separate video. But eclampsia is a medical emergency. So eclampsia is a great example of where we might need to deliver preterm or even in a pre-viable period, because it is such a serious medical emergency that you have to take that risk. But let's talk through this really quick. What is preeclampsia? I'm sure many of you have heard that term before, but what are we talking about? So preeclampsia is hypertension after 20 weeks, so that similar period as gestational hypertension, but the difference here is that there is presence of end organ damage. So you have hypertension and you have damage to other organs, and this is why preeclampsia can be so dangerous. And then what's the difference between preeclampsia and eclampsia? Well, a lot of the same things will put you into the eclampsia box, but eclampsia is essentially preeclampsia plus seizures. So if you have seizures, you are now in eclampsia, and that is going to also drastically change how we manage this situation. So the pathophysiology of eclampsia and preeclampsia is we have this placenta here, right? So we have the baby that's attached to the placenta. The placenta is the interface between the pregnant parent and the baby. So any blood flow that's going to be getting to the baby has to go through the placenta first. And so when the placenta is forming, this is going to be a very simplified explanation. The placenta has to invade the uterine tissue, and it has to form these connections via arteries. The spiral arteries have to grow, and they have to be wide enough in order to accommodate blood flow from the parent to the placenta so that the baby can then get that blood flow. You need these to be wide enough in order to allow enough blood to go through and circulate through the baby. So then what happens if we have preeclampsia? Well, these arteries grow, but they're very small and narrow. So we don't have enough that can get through at one time, and we're going to increase the blood pressure in the parent because the blood has nowhere to go. It can't all fit through here to go through the circulation. But this baby is going to need blood flow, right? So this baby is going to get hypoxic because it can't get the blood. But then the parent's going to get high blood pressure because now the parent has enough blood for the baby, but it can't really go across into the placenta. So this is why this is such a difficult issue. Because now we have a baby that is at risk. Just by having preeclampsia, your baby is at risk, and also the parent is now at risk. They are both at risk for serious complications. So there's one treatment, one cure for eclampsia and preeclampsia, and that is delivery of the fetus. It's the only thing we can do to get rid of preeclampsia is deliver the fetus. All right, so what would classify someone as having preeclampsia without severe features versus preeclampsia with severe features? So I know ACOG recently has changed their guidelines to make there more overlap between with severe features and without severe features so that clinicians can have more leeway and freedom to use their clinical judgment to say this patient is stable enough, we don't need to induce delivery right away, versus severe features where someone might be very unstable and delivery is going to be necessary. So we have these two categories to make sure that we can assign the correct treatment to these people. And we're going to do that with differentiating if their organ damage is severe or not. So how do we classify someone as without severe features? What does this mean? So as we said, preeclampsia is hypertension after 20 weeks gestation with signs of end organ damage. So your blood pressure range in this case is going to be 140 systolic or greater and 90 diastolic or greater. So 140 over 90 is kind of the magic number with regard to preeclampsia. But you can't just have the blood pressure range. You also have to have signs of organ damage, and this is usually in the form of proteinuria, which is protein in your urine, or it could be other signs of end organ damage. But as you'll see in a minute, many of these overlap with severe features. And again, this is because ACOG wanted to make sure that clinicians could appropriately apply treatment to somebody who they deemed was unstable. But for the purposes of this video, we're just going to talk about it in terms of the medical boards. We're going to keep it very simple. So in this case, preeclampsia without severe features is going to be a blood pressure 140 over 90 or above, plus proteinuria or other less severe signs of end organ damage. All right, so then what classifies as severe features? So one thing that would automatically differentiate you is a blood pressure 160 over 110 or greater is going to automatically qualify you for severe features. But unlike preeclampsia without severe features, you do not also need to have the proteinuria or another sign of end organ damage. You could just have this blood pressure range and be classified as severe features, or you could have one of these next things that I'm going to list off, and that would also qualify you for severe features. And so you just basically have to justify that a person has organ failure, some kind of organ failure, and there are a few ways that we might determine this. So the first one is a creatinine greater than 1.1 or 2 times the normal limit. That would be a sign of kidney failure. And then platelets less than or equal to 100,000. So normally the lower limit of a normal platelet count is 150,000. So anything less than 100,000 is really, really low. You are at risk for bleeding out or having a condition called DIC. You have lots of problems potentially happening here, but platelets are produced by the liver. So if you have low platelets, then that means your liver is probably failing. Same thing with increased LFT, stands for liver function test. So if you have elevated liver enzymes greater than 2 times the normal limit, then that is considered to be liver failure and would be a severe feature. Pulmonary edema is fluid in your lungs. This is severe because you can't breathe very well with fluid in your lungs. You might tank very quickly due to hypoxemia. So that is a severe feature. Visual disturbance and severe headache, you would not normally think of as being severe features. But if you think about it, both of these are signs of nervous system damage. If you start experiencing blindness, or if you have a severe headache, and when I say severe headache, I mean like worst headache you've ever had in your life, that is a sign of CNS damage, CNS failure, and that would classify you as severe features. So again, some of these features you might see in someone who is preeclamptic without severe features, but for this, we're using it in terms of severe features because if you have severe enough organ damage, you're going to need to treat it differently. So how differently do we treat this? So for someone who is preeclamptic without severe features, studies have shown that it's better for the fetus and it's okay for the parents if you leave the baby to gestate until 37 weeks. There's not any real increased risk of waiting to deliver, but you still don't want to hold the baby in too long because there is still risk. So you can wait until term. You're going to wait until 37 weeks, which is the earliest range for term, and then you would induce a delivery, which, as I mentioned in the last video, that is a termination. You are terminating the pregnancy. You are inducing a delivery, and at 37 weeks, that is term. So it's not like you are terminating at a stage of gestation where the baby is not really going to survive. This is considered viable. But you're still delivering earlier with an induction maybe than they would have organically had. And then with someone with severe features, it is more dangerous to keep the baby gestating than it is to take the gamble, deliver the baby, and let the parent recover. Because these signs of end organ damage mean that the fetus is not going to last long if it's going to stay in. So the idea for severe features is that you're going to deliver, you're going to induce a delivery at 34 weeks gestation, which is preterm. So it's still within the viable period, but it is not term. Most of the time, for any random reason where you didn't have medical indications, you're not going to want to deliver at 34 weeks because it's still not likely that the fetus is going to survive. You're going to have a lot more work you got to do with that fetus if you're delivering at 34 weeks. But with severe features of preeclampsia, it is going to be safer to deliver the fetus at 34 weeks and to let them both see how they're going to do. And you're going to have greater chances of parental viability as well as gestational viability. So then eclampsia. Eclampsia is incredibly serious. As I mentioned, it is hypertension in pregnancy with seizures. So seizures are very serious. They're definitely a sign of nervous system damage. And for this, you are going to deliver at any stage of the pregnancy. It does not matter if the fetus is viable. So it doesn't matter if it's before 20 weeks. It doesn't matter if it's in the preterm period. You need to deliver the fetus. You need to terminate the pregnancy and deliver the fetus at any stage. And if this was before 20 weeks, if you got eclampsia, if you have seizures, and you need to deliver before 20 weeks, this is an abortion. It is a termination. So this is a case where the risks of gestating outweigh the benefits of gestating. So you are going to deliver at any stage if they have eclampsia. Because the pregnant parent always takes priority until postpartum. And the reason why, if you have a dead parent, then you have a dead baby. The survival of the gestation depends on the survival of the gestating parent. So we have to prioritize. It would be great if we could just save both every single time. That would be fantastic. But we can't always do that. Sometimes we have to gamble, and sometimes we have to pick one or the other. And you can't save the gestation unless you can save the parent. So the pregnant parent always takes priority until that baby is delivered. So I hope all of this made sense. It was kind of a heavy video again. Please leave your questions and comments down below, and I will see you all in the next one.